So I'm Brent from Hamilton again, and I'm just going to give you a good overview of our program that is focusing on hard-to-reach individuals called the Social Navigator Program. Here's a little preview.
I'm the Paramedic Social Navigator that's been assigned to this position. When the action team was implemented back in May of 2010, there was a need to identify those individuals who were what they would categorize or classify as at risk due to mental health, addictions, and homelessness, that there was repeat interaction with the police. So the police came up with this idea about having a referral system to the agencies within the city.
What the Social Navigator program does, it brings all of our social agencies together at one table, and it allows us to have open discussions about individuals who need the support of our community, and it helps them to get into the proper support systems and proper care.
Yesterday I dealt with a gentleman who suffers from a mental health issue. There's something not right. I couldn't get it out of him what the actual condition was.
The intent of the program is to identify those individuals through police reference and sometimes external references.
And when I saw Patrick this morning, I mentioned this gentleman that we saw yesterday. So when he saw me out on patrol today, we stopped just to make sure that he's not on the streets, and if I had seen him, then we could point him out to Pat. Hopefully get this guy some help.
The Social Navigator now changes the dialogue when we discuss the people with these vulnerabilities to a circle of care, and the social agencies come together to provide the care that they possess.
So my role really is to assess those individuals that come to my attention and see how best I can get them connected or reconnected or augment their relationship with either a new service or existing service.
But the Social Navigator is a process of getting the proper assistance to people who need it, and a lot of time it's just about connecting the people with the proper service that they require. Our action strategy officers are out there every single day. You'll see the officers are out there because people who are out on the street that need our assistance, that need the care of the Social Navigator, they're out there all the time as well, so we'll be there to help them.
Thanks for that. Yeah. So that's our Social Navigator program. I guess I can sit down now. I'll go over a couple, just a little bit more of the background, talk about a little bit of the results. We've done a couple annual reports, and in the future, hopefully, we'll kind of standardize it and turn it into some publishable work that my good friend Peter from Australia stresses when we chit-chat at the table there. It was, I think it was mentioned it was hard to do a meta-analysis on unpublished work, something like that. So, thank you. Right, okay, so in 2010, the Hamilton Police, along with the city, they wanted to revitalize the downtown core revitalization program. So they put 40 uniformed and highly visible officers to walk the beat in the core, which is probably about 3 kilometers long and about 1 kilometer wide of downtown Hamilton, rough part of town, and they just wanted to make sure that, they were cleaning it up, getting people panhandling off the streets. They are handing out tickets, arresting people, putting people in jail, court system, judicial system, overstressed. But then they realized that this type of, punishment or this tactic wasn't really working very well. So they thought, and these people were repeating their interactions, they're repeating their violations, so they knew that they needed to do something else, that the ticketing isn't working. So they called upon, they realized that a lot of the patients had mental health, addiction issues. They didn't have funds, low income, they didn't have jobs, and they didn't have stable housing. So that's how the Social Navigator Program came about. Sorry. There we go. So yeah, like the video said, our goals are to connect the people that are most often disconnected. They don't have any services, or they've lost services because they don't like to follow rules or what have you. And then obviously reduce the strain on the judicial system, primarily at the very beginning, and now the healthcare system, of course, too. Our main outcomes, we discussed that a little bit in the video, were improve clients' ability to access and utilize health and community services, improve their lives, decrease their interactions with police, and decrease or identify our vexatious callers and paramedic services. And then the collaborations in the community, the police and paramedic service and the other community agencies. So the program came about with three main partners. Wesley Urban Ministries, which is a community service that is a nonprofit organization. We partnered up with obviously Hamilton Police and Hamilton Paramedic Service. Along with the city, they also funded the city funded a pilot study. Actually, they're funding it as pilot study into 2016 as the neighborhood renewal project. So we've identified the team members. We have a coordinator who kind of coordinates all the appointments. She kind of tells paramedics and the police officer what to do. So there's a police officer as a team member and a social navigator paramedic. I'm there to support as a supervisor. I support the paramedic in any of his needs. He actually will respond to 911 calls if they're code 4 or urgent, and if he's in the area. So yesterday it was discussed that paramedics have we're kind of strategically placed in the community, and we can access or like their knowledge, their experience to find these people, enhance that with the police and their intel. It's pretty amazing where we can find these people. We have one client who just set up camp on the escarpment. Hamilton's built kind of like, they call it the mountain, but it's only about 300 feet or something. I don't know how big it is. But it's up on this escarpment, the Niagara Escarpment. If you're down that way, have a look. He was just like, had a whole setup. We had to talk to him because he couldn't stay there, and he was trespassing. But the ability to find these people and to get them the help that they need is really crucial. The uniform is a little bit different than the police uniform. There's no gun, there's no intimidation factor, so the trust and the openness that these patients initially have with the paramedic is quite amazing when you compare that to the police officers that are out there as well. We get more results and quicker results. So the criteria to get a client into the program, the police at the beginning would only send patients to the Social Navigator Program. There's no other referral process, so someone from the community can refer. We're now looking at high users in EMS, the vexatious users in our paramedic service. We're now sending them those patients, or clients, I should say now. And anyways, there's the list of the criteria. We intervene in the critical moments, so bail hearings, when they're being discharged or released from jail, being discharged from the hospitals or the mental health institutions that they're getting help from. We help them in times of need when they're getting evicted from their homes. And we're like a great safety net for these, and we're really meshing the services together so these people don't fall through the cracks again. Some unexpected developments. In 2012, the courts kind of recognized how vital this program was in Hamilton, and they started mandating the clients to the program. So we would set up, the courts would then stipulate that the person on their release conditions would have to report to the social navigator under an example of these terms here, which is pretty exciting. Just earlier this year, the judicial system gave us permission to do professional visits in the jail. So Paramedic is now allowed to go into the jail, into where they're staying, connect with their clients, talk to them, and set up a plan, especially for finding housing and stuff, right from the jail, which is like not even a regular police officer can go into the jail and talk to people like that. So it was pretty exciting. My new paramedic is not Pat. Pat is our old paramedic. We have a new paramedic. His name is Gord, and he's just loving the whole thing. It's kind of opening up a whole new can of worms. We did some surveying for the community services. So some of the themes are bringing us together, all the services together. We're really prompt during the hours that we work, 8 to 4. Otherwise, there's a few that are falling through the cracks there, but we're hoping to expand that on some more funding that we've kind of just secured. Just an overview of some demographics of our patients. We see that the average age is 37. That hasn't changed over the years much. A neat thing to note is the mental health illness, the highest, the most prominent illness is schizophrenia that we've dealt with. The Social Navigator Paramedic, he's an advocate at the appointments. These people, aren't able to convey what's actually going on with them when they go to medical appointments, and they're just he just acts as a great advocate for these hard to reach people. So our stats for the program. I can't see where it's going. Anyway, as you can see, it's just going up. All our referrals from the police services, and then now we've actually put some of our paramedics patients in there as well. So there is a huge need for us to expand and put another social navigator in there. Just the workload is too demanding, and this report that we just finished for the 2015 was part of our leverage to go to council and get some more funding for that. On average week, we see and connect with 23 clients that are usually current. We take on 1 or 2 new clients a week, and they attend court and on behalf of the Crown or whatever, we speak on behalf of the patient and give evidence to help out the patient, whether it's a court mandated and different programs that they have to follow. And then we do attend lots of meetings, so a couple a week. Some of the common referrals that we make for those clients: mental health, obviously the primary one, and we connect them with primary health care, which is key, because they forget to go to appointments and things like that. So. Some of our outcomes, we see a big decrease in mental health calls for the police officers. So this is some older data that we're looking at here. But this population, as you can see, it kind of falls off track. So we're always kind of revisiting new patients or previously discharged patients just to get them back on track. So we know that there's a piece of the program that we always have to monitor how the previous clients are doing, just to make sure they're not falling through the cracks again. Some of our data for paramedic services, we have about 40% of our client intake have called 911 once or twice. They make up a lot of the transports in total. So this in 2014 is 130, but then the next year our clients gone up a little bit there because we had to put a push and we pushed a lot of patients over there from the paramedic service, up to 48 transports just for 45 clients. One of our clients is 82. He came to Hamilton in September, so I was, he did a lot of work with our guys, our frontline guys. So here's an example. Let's leave you with my case study of a vexatious caller who we worked with over 2 years approximately. She's an alcoholic in her 50s, had her own home, but just kept on calling all the time. Whenever she was drunk, whenever she wasn't drunk, whenever she ran out of booze, she needed more booze, whatever, she called. So we were able to charge her at the end of 2014 with conveying false messages, which was the first time we were able to do that for like a strictly just a paramedic patient that we had, paramedic services overusage and vexatious caller. So what that did allowed us is she did serve some jail time, but she also was mandated to go to different programs and report to the Social Navigator Paramedic, which was really exciting. We would set her up with group homes. She would get kicked out of group homes. One of her conditions was to never go back to her apartment that she owns. And then she'd manage to get herself back there and call 911 again. And then obviously she breached, and we could tell that she breached because we're picking her up at her home. And so then the whole process kind of started over again. So that's why we're seeing little like 13 calls with her. So yeah, we have another one that we just charged actually, and he's in court on Monday. So it's kind of a different look, I guess, on dealing with high users and actually putting them through the judicial system and stuff. But it seems to be working, and our next steps are to standardize the program a little bit more, make the data that we're collecting more robust. We're on paper right now for this particular program. But we're working with McMaster University and the CHAP EMS team. We're going to be, setting up some program evaluation, and hopefully expanding to other regions. We have a neighboring region that's going to come in and shadow our program for about a day or two later this month, actually. So we're excited about that. And if you guys have any questions or anything before I let you go to lunch. That's it for me for now.